Well, I'm just going to talk a little bit about how the medication management things go, like our appointments. And then I'm going to talk a little bit more about like medications and like common questions that you guys might get associated with medications. So first, we'll talk a little bit about what your clients can expect from a medication management appointment. Um, First, if they're a new client, then they're going to be filling out all of the required paperwork, obviously. It just might be a couple extra pieces of paperwork than what you guys require as therapists. Some of the extra questionnaires and diagnostic scales might be the mood disorder questionnaire, the CAGE, the audit, the ASRS, and the CSSRS. It also depends on how long ago your clients filled those out. So if it had been a year, we might ask them to refill them out. So if they are inquiring about medications, just let them know that there might be a little extra paperwork that they have to fill out. If it is a child / adolescent, we will be meeting with the parent first virtually before having another intake with the child in person. Medications will not be prescribed until meeting the child in person due to having to take vital signs and just getting to know the situation a little bit more delicately since it is a child. At least one person intake is required to take the client's vital signs. Afterwards, telehealth can be used for follow-ups. So just tell them like, hey, it's just one time in person, and then it can be telehealth. Medications do not have to be prescribed at the end of the intake process. This meeting can just be a way for your client to gain more information on their options on medications, determine if this is a good option for them, the options of medications that are available to them, and just kind of have their questions be answered about medications. It can be a really scary thought to have to get on medications. So just having their worries answered can be really helpful. We also like to have a quick follow-up after we're prescribed a medication for them to check for tolerability and effectiveness. So it's not like we're prescribing a medication and then not seeing the client for a month or 2 months at a time. We usually like to see them within 2 weeks of having them start that medication, just so we can make sure that there's no really serious adverse effects. So they don't feel like they're just being thrown to the wolves and with no one to reach out to. I'd like to go over some medications that you guys are probably going to see the most often. These are medications that are prescribed for anxiety, OCD, and depression. First line is the SSRIs, or the selective serotonin reuptake inhibitors. These are the ones that you know really well: Prozac or fluoxetine, sertraline, or Zoloft, escitalopram or Lexapro. Some of the lesser known ones is citalopram and paroxetine. But these are the ones that like people think of when they're talking about antidepressants. Some common side effects from these medications: nausea, diarrhea, headache, drowsiness. And these symptoms should only last the first 2 weeks of taking the medications. After the 2 weeks are over, we should see a decline in the side effects, if not them totally disappearing. Other side effects can include sexual dysfunction and weight changes. Weight changes, usually not so much. It's more so when people have a form of depression where they don't eat as much, and when they start eating, like when they start taking the medication, they might start eating more and notice some weight gain, but it's usually not to a point where it's like excessive weight gain. Um, these medications usually take between 4 to 6 weeks to have full therapeutic effect. So we like to be patient with these medications. We like to ask clients to tolerate some of the side effects as long as they're not totally running and ruining their lives, to see if there's any positive effects at the 4 to 6 week mark. There is a black box warning for these medications. There has been found that it will increase suicidality in acutely suicidal clients that are 25 years and younger. So having a client who's acutely suicidal and starting the medications, you want to really be watchful for if they start having intent or start developing a plan with those suicidal ideations after they start taking the medication. Weighing the benefits and risks for these clients is always recommended. Usually we will start a medication, but just making sure everyone's aware of the risk and keeping them under close watch during those first couple weeks while taking the medication. Clients here at LOA, at least the way me and Mary Grace practice, they'll always be started on the lowest dose possible to try and avoid side effects. And they will receive increased doses based on tolerability and effectiveness. So when a client comes and sees me, I like to talk to them about what the lowest possible dose they can take is. Some people say we're starting them on Zoloft or sertraline. Some people like to be started on the 25 milligrams, which is the lowest dose clinically that we have, or they like to even cut that lowest dose in half to 12.5 to really ease themselves into taking the medications. And I'm totally for that. It's all about making the client comfortable with the medications, especially if it's their first time. If they start taking the medication and the side effects are tolerable or they're going away, but they're not experiencing any really positive side effects, that's when we look to increasing the dose. We always want to get to the lowest therapeutic effective dose for them. The next medications are SNRIs. This is the desvenlafaxine, duloxetine, and venlafaxine. These are the second choice. We usually like to exhaust kind of a couple SSRIs before we get to the SNRIs. Some common side effects for these are nausea, dry mouth, dizziness, headache, and those also should only last the first 2 weeks. So they have a lot more dryness side effects because of the norepinephrine that's also being affected. Also, other side effects include constipation, sexual dysfunction, and drowsiness. These medications also take about 4 to 6 weeks to get a full therapeutic effect. With these medications, specifically, stopping them abruptly will cause really bad discontinuation syndrome. It presents as flu-like symptoms, so muscle aches, nausea, vomiting, and we don't want people to go through that because it can be really, really terrible. So we suggest slowly tapering off the medications, especially with the guidance of someone with the medication management team. These medications can also help with chronic pain, especially nerve pain. So if a client has chronic or nerve pain, but also is dealing with anxiety, depression, it might be beneficial, kind of like hitting 2 birds with 1 stone with starting them on these medications. The next medications, as we move on with these medications, you're going to see them less and less because we're getting into the older types of antidepressants. So the tricyclic antidepressants, I'm not going to say all of them, but amitriptyline, doxepin, clomipramine. They also get harder to pronounce the further you go down. These are considered the first generation antidepressants, but they are not considered the first line. So they're kind of like what people were started on before the SSRIs and the SNRIs were produced. Common side effects for these, again, the constipation, dry mouth, dizziness, but these side effects tend to be worse than the SNRIs with the urinary retention, blurred vision, fast heartbeat, and some weight gain. This medication can also be used in an overdose and can be fatal if not treated in time, whereas SSRIs, we don't suggest that you take them all at the same time, but it's not likely that the overdose will be fatal if they're all taken at the same time, whereas these medications, the overdose can be fatal very quickly. So assessing for suicidality when you have a client that's taking these medications is important because it's just not good. The last kinds of these medications is the monoamine oxidase inhibitors, or the MAOIs, as you'll probably hear them be called. These were the first type of antidepressants ever invented. They're typically only prescribed if all of their classes of antidepressants have not improved symptoms at all, or if there is, it's very treatment-resistant depression. It works by increasing multiple neurotransmitters in the brain by stopping the breakdown of like serotonin, norepinephrine, dopamine, and triamine. So it's just stopping the breakdown of these, but it's not as selective as the SSRIs or the SNRIs because it's a bunch of different neurotransmitters instead of just one or two. Some common side effects: dizziness, dry mouth, nausea, diarrhea, constipation, drowsiness, and insomnia. There's also an increased risk of serotonin syndrome just because it's not, like I said, as selective with the neurotransmitters, especially the serotonin. So we might have an increase in serotonin that might be too high. We also have to avoid tyramine-rich foods with this medication, which is aged cheese, soy sauce, cured fish, fermented sausages, overripe fruit, fermented beers, just a whole bunch of different foods. A lot of foods that are aged or fermented have to be avoided, which can be difficult for some people. If they like to eat those foods. Now I'd like to talk a little bit about psychiatric medication and pregnancy/family planning, because I feel like this, especially in like the River North office, we have a lot of young adults in their late 20s, early 30s who might be looking to family plan or get pregnant soon. The use of psychotropic medications in pregnant individuals is a concern due to risks of adverse perinatal and postnatal outcomes for the infant. But advising these individuals to discontinue the medication also presents risks with untreated or inadequately treated mental health that can put unnecessary stress on the developing fetus, but also there might be poor adherence to prenatal care, inadequate nutrition, and increased use of alcohol and tobacco on the pregnant individual's side. Of course, decisions about medications should happen ideally before pregnancy, but that's not always the case, and that's okay if it happens. We can always develop a plan. We always want the fewest amounts of medications at the lowest therapeutic dose. So if your client is on, say, multiple medications, we want to try and lower the amount of medications and just like take the one that's been working the best and have it be just at the lowest therapeutic dose, that they're not relapsing into depression or anxiety, but also not on 2 or 3 or 4 meds at the same time. Typically, most SSRIs, SNRIs, and bupropion can be used safely in pregnancy. The only SSRI that is not recommended is Paxil, and that's due to increase in heart defects. When you get into mood stabilizers and antipsychotics, it's a little bit more dicey. So, but I know we don't see a ton of those here at LOA. So, but if in the future you guys want me to cover more in depth about the pregnancy risks with those types of medications, we can definitely do that. Always we can coordinate with the client's OB doctor to make sure everything is as safe as it can be. They know that taking somebody off of medications that is stabilizing their mental illness is also not good for the mother or the fetus. So they want to treat the mom as best as they can without putting the baby in as much bad medications as possible too. So collaborate, and they know a lot more about what can be helpful and what can't be helpful than for the fetus than we do. So collaborating with them is always a good idea. Next, I wanted to talk about some medications to aid in insomnia. I feel like this is a big thing that people come to us with, is saying that they can't sleep at night. So covering some medications that could be helpful for them is always a good idea. Cognitive behavioral therapy for insomnia is always the preferred first-line treatment for chronic insomnia in adults, but sometimes adding medications can help a little bit. Benzodiazepine hypnotics. These are the benzos that also help with anxiety. But we generally we avoid using these for insomnia due to the longer half-lives and higher risk of dependency, and there is safer options out there. So we don't use these as often. For this might be more so somebody who is not sleeping at all and really needs to kind of be knocked out so that they can get some sleep, so they don't get into an even worse mental state. And it would be for a very, very short time. Next is the non-benzodiazepine. Benzodiazepines, essentially, kind of like the ones that aren't also used for anxiety. These are ones that you'll probably know, like Ambien, things like that. They have a shorter half-life and reduce the risk of daytime sedation and impairment compared to like the benzodiazepine hypnotic. So you're not going to wake up as exhausted. But for these medications, there is a black box warning that was added in 2019 on the risk of rare but serious complex sleep-related behaviors. These are behaviors like getting up and cooking, and getting up and walking the streets, and getting up and driving your car when you're still asleep, actually. There's been a lot of documented reports of that kind of behavior. And if this does happen with your client, like if they mention it to you that it happening, you should instruct them to stop taking this medication, because it is contraindicated for people who are experiencing those types of behaviors when taking these medications. Sometimes they won't tell the people who actually prescribe the medication because they don't want it taken away, because they do work really well, but we don't want them driving their car while also asleep. Another medication that we use is low dose doxepine. Doxepine is a tricyclic antidepressant. It's unique in this antidepressant class because it has an antihistaminic activity that enhances sleep maintenance. So this medication is more so for the people who are waking up in the middle of the night, and not for the people that are having a hard time falling asleep. Most common side effects are sedation, which we want, nausea, and upper respiratory tract infection. We want to avoid this in clients with untreated angle closure, glaucoma, or severe urinary retention, just because it causes more of that, causes more urinary retention, and these people don't need that. There is no abuse potential for the doxepine though, which is different from the benzo options. Another medication is Ramulton. This is a melatonin receptor agonist, and it's approved for the treatment of sleep onset insomnia. The most common side effects, again, are sleepiness, dizziness, fatigue, and exacerbation of insomnia. So for some people, it does the complete opposite of what we want it to do, and it makes them more awake, which doesn't make sense, but it does happen. There are rare reports of decreased testosterone and increased prolactin with this medication. So if your client starts having like milk discharge from their breast area, then they would want to get their prolactin levels checked with this medication. Again, there's no abuse potential for this medication. Some other antidepressants with sedating effects are trazodone, mirtazapine, and amitriptyline. These medications aren't suggested for clients that are not also depressed. It does have sedating effects, but there are other side effects that might not be as tolerable. But if they are also depressed and taking these medications to help treat their depression, then it might be worth kind of killing two birds with one stone. Another question that I feel like people get a lot about medications is how to combat medication-induced sexual dysfunction. Sexual dysfunction is a side effect that is found in some psychotropic medications, and this can be described as either low libido or erectile dysfunction. It can be both or either or. Sexual side effects may subside at a lower but still therapeutic dose of the medication that they're taking, but they should not try to see if this is the case without the help from the clinician. It's kind of a benefits/risks kind of thing. And also lowering their dose without help could be dangerous for them. Some ways that we can combat it is scheduling sex at a time where the side effect is less bothersome, and taking the drug at different times if possible. So if, they want to do it at night and they are taking the medication at night and the side effect comes up like pretty soon after taking the medication, then moving the medication to the morning might be a better option for them. Starting a medication like bupropion has been shown to improve sexual response. It has been found to counter SSRI-induced sexual dysfunction by boosting sexual drive and arousal, and it's a medication that we use often that we add on to whatever medication is causing the sexual dysfunction to try and balance it out. Bupropion or Buscapar can also be added to increase libido and restore the ability to have an orgasm. And then there's medications like Viagra and Cialis that can be taken by men for erectile dysfunction, if that is what is going on. A question that we as medication management, I'm sure you guys get a lot, is how long do I have to take my medications for? The recommended timeline to take these medications depends on a few factors. If this is a recurrent problem for the client and it's severe, we usually don't have a timeline for how long the client has to take these medications. It can be sometimes indefinitely, depending on how recurrent it is and if it becomes really severe for the client. If it's the first or second time this client has had these symptoms, like they had like 20 years in between the symptoms, and it's kind of a mild to moderate case, we usually ask the clients to try and take the medications for 6 months to a year, symptom free or lower symptoms, before we have the discussion of coming off the medication. Usually when we have those discussions, it's to help taper the medication since they've been on it for so long in a safe and effective way that won't re-trigger their anxiety or depression, and so that they can live their life without the medication. With that being said, clients can always refuse medication at any point in treatment and can be taken off of them if they are persistent and do not want to be on the medication anymore. We as the clinicians will always try to discuss the benefits and risks of stopping the medication prematurely with the client and try to get them to understand why it might not be the best idea. But we will always listen to what the client wants and try to help the client come off the medication in a safe fashion where they're not having rebounds or relapsing on their depression or anxiety, as well as not having any withdrawal symptoms or discontinuation syndrome with the medication. That's kind of all I had. I didn't know if anyone had any questions. And then I had my resources here.
Thank you, Lauren. Yeah, I would say if anybody wants, feel free to just call out your questions or put them in the chat. I didn't see anything in the chat quite yet, but lots of applause.
Hey, Lauren, it's Brian.
Hey.
Hey, can we ask almost like a case question? Would that be appropriate for here?
I think that would be great to ask case questions for everybody, Brian. So thanks for thinking of that. So let's all think about cases and the medications that we're hearing people on, and let's come at Lauren with them. So
Cool.
Brian, you go
Try
first.
to answer them.
All right. So actually, I'm sharing a client with the other Lauren, who's here too, Lauren T, who's been for like the last month coming down off of Effexor, and I don't want to say complaining, but saying that they have a lot of, like, they're always under the weather, have flu-like symptoms, but they've been, like, I always thought, they stopped abruptly and they said no. They're like, I was like, okay, when did you last take it? And they're like, this morning. And so it's been over a month of every time I meet with them, they're saying they're, feeling this miserable. But to me also, it doesn't quite make sense. And so they haven't really stopped. They've just reduced. So I don't know, because you saw your slide where you talked about it, but it said like abrupt stopping. So it was just really confusing for me when every time I've run into this client to see how like miserable they are, and they keep attributing it to that. I don't know if, in your knowledge, there's maybe another reason or something.
Sadly, Effexor is one of those medications that even if we could go the slowest possible, it's still going to have really like flu-like negative symptoms for people. We don't really know why, but our body becomes very dependent on that specific medication, not in an addiction way, but in like the body really reacts negatively when we do start taking it away. So it is something that we try to warn the clients about, like with that specific medication, it is going to not be comfortable even if we go very, very slow. Usually we try to also warn them that before they start taking the medication, because if we get started on the medication and we find that it's not really a great fit, then it's kind of a pain in the butt to come back down from it. It's not our favorite medication either, because we don't want our people to be in any kind of discomfort, but it is sadly one of those medications that you are going to be in discomfort while coming off of it, even if slowly.
Thank you so much. Yeah, that's what when working with the client, I've kind of, because I've heard something similar to that before, but I was like, well, I'm not a medication person, but I heard it's really tough. For me, it was like, okay, we're a month in now. Okay, is this the same? But thank you so much for sharing that information.
Yeah, of course. I see a question from Sarah. She asked if the bupropion for sexual dysfunction would be in place of SSRI or in addition, and it's usually in addition to the SSRI. Bupropion by itself isn't really effective in treating all of the depression. It is good for giving a little bit of energy. It's typically a like addition medication. So it's good at giving a little bit of energy to people who are low on energy, as well as helping with sexual dysfunction. So yeah, it would definitely be in addition to an SSRI. No problem.
Other cases and/or questions?
Oh, I could ask a question. Do you guys hear me okay?
Mhm.
Okay, I just landed in an airport, so there was some background noise. But Lauren, this has been so helpful. And I have a case, and actually, I'm gonna be having you join me to meet with this client in the next couple of weeks anyway. So it might be a good opportunity to tell you and everyone a little bit what's going on with him medication wise and then what you think could be helpful. So just a little background, like let's say a 32-year-old moderate to severe OCD with mainly thinking compulsion. So lots of mental compulsions around trying to make sure, like if he gets something, if he's about to send an email, making sure he's looking at it the right way to make sure it's just right enough that if he sends the wrong email, it might like blow up the deal he's working on. And over the last year or two, he was never on medication. I've been able to get him to be willing to try medication, but he's always been very resistant to it. He shouldn't need it. And just, he's so hypersensitive to his physiology. So whenever he takes anything, all of a sudden, that is a new side effect of feeling low energy or impact on his sleep. So in terms of it, he's now on like a pretty therapeutic dose of an SSRI and an OCD dose of SSRI, which is good. And I'd say symptoms have gone down 50%, but he still spends a lot of time ruminating and a lot of OCD about OCD. So feeling kind of depressed or down whenever his OCD comes up, even if he could get unstuck from the thought, he then feels really frustrated and down. Why am I still having it? And so a lot of compulsions around that he has to live with this at all. It almost has like a depressed like feeling to it. And there's also like an intentional quality. Like he has a hard time redirecting himself. Even though he probably could, it just feels like he needs to squash the thought. Otherwise, that's a sign he's going to always live with OCD. So I don't know if there's any, you're going to do an intake with him and you'll get to know him more, but what other questions would you be thinking out in starting to consider if there's any enhancements on the medication front for a client like him?
I'd definitely be asking, obviously, what medication he's on and what dose he's on, how that dose has made him feel, and if he feels like it has stayed, like the effectiveness has stayed the same, or if it has gone down. With these medications, sometimes we can hit a point where we're getting a lot of therapeutic advantages, like it's feeling good, and then it kind of plateaus, but we're not quite at the place where we want to be with the medication, like how we're feeling with the medication. So increasing the dose could be an option for him, as well as maybe switching to a medication that has more range for us to move around with the dosing and might in the long run be a better fit for him. I know as well with the going back, the tricyclic antidepressants. There is one, the clomipramine, that is like considered the gold standard for OCD treatment. We don't like to start people on that medication just because of all the side effects that happen with it. And we know a lot of people that have anxiety symptoms aren't the best at dealing with a lot of side effects, but it is considered the gold standard for OCD treatment. So if we trial him on a couple of different medications of SSRIs and maybe an SNRI, and those don't seem to work, then it might be beneficial for him to be on a medication like clomipramine that might have a couple more side effects that he has to deal with, but also is highly likely to help with the OCD.
I should look more into this, but I've always suspected a little bit of an undiagnosed ADHD where once these thoughts come up and he gets very distracted by them and also by different things in life. I guess in terms of co-occurring ADHD and moderate OCD, what medication would you throw in the mix?
If he has ADHD, I would suggest starting him on a stimulant. Maybe something at a lower dose so that it doesn't aggravate his anxiety. But if it could help him focus during the day and not get so caught up in his thoughts, then it would be beneficial to look into. For somebody who is an adult, we do suggest that they go to the neuropsych to get officially diagnosed.
Yeah.
So that we can start with the stimulants. Yeah.
Yeah, no, that's really helpful because I think it's this mental compulsion of ruminating that is harder for him given his attention. So yeah, that's helpful. I'll kind of explore with him a little bit too. So thank you.
Yeah, of course.
I don't want to, I love all the clinical talk, so I don't want to speak separately to that, but before Dr. Kizin asked her question, I was also thinking, Lauren, people that come to us at Let Anxiety who already have a prescriber or somebody who's already on medication, and Dr. Kizin saying like, I'm going to schedule an intake with you. Is there ever, do clinicians feel comfortable if there's a prescriber that they're working with externally? It's amazing here to have the support from our medication management team because we're collaborating so closely. Of course, we're collaborating externally as well. But do you guys ever feel like, well, this person already has a psychiatrist or this person already has somebody? Would it be a comfortable situation? And I hope it would, but I'm just curious what that feels like to say, well, we have medication management prescribers here. Let's get some more information. Let's just have a conversation.
I think the key, I think the key to bridging that gap is we're never coming off saying like, wow, they prescribed that. Like that was the first choice and so they haven't called you back in a week. That's really concerning. I try to Socratic questioning in terms of, well, did you feel heard when you shared that information? So I think I'm not trying to lead them to my conclusion, but by just being caring and asking questions and if they are saying like they're not happy or they're interested in a second opinion, but never, of course, starting with, unless they're making it very, very clear that it's just, I've seen it egregious enough that I'm like, you really do deserve someone to call you back out. there may be a point of pointing out like just how their rights in navigating a situation, and that's okay too. But we're always, of course, considering what's going to make their life easier and how can we help them determine what's a helpful next step. Lisa, does that answer the question kind of?
Yeah, it does. It does. I know. So I'll just share. I know a family that is seen here at Light on Anxiety, and they have a psychiatrist that is an external psychiatrist. And just the stories I've heard, just by being a friend, I'm like, God, I wish you would just go see Lauren or Mary Grace. Like, I just feel like the support. And so I think for me, that's maybe what's coming up for me is they don't know that there are different options. They don't know. And for you guys to feel comfortable saying, well, I'm not. And so, yes, you did answer it by saying, even if this person maybe is getting back to you, I'm thinking of Brian's client who is on this medication, and Lauren saying, we probably might not have started with that one first, but somehow the client is on it. So I just think of the wonderful work that we do here and how to, we're not medication prescribers ourselves, but in hearing what we do, are there ways that we might want to help our clients just by getting them more information that you guys are not prescribers. You don't need to teach them this, but we have amazing people here that could. How do we get them that information in a gentle
and
way?
I think the key is it's about empowerment. It's of course not a sales thing, but it's an empowerment in turn, and also education on what as a healthcare consumer is out there too. Because if the only options were to have to wait 3 weeks or to have a 5-minute meeting where nobody is hearing your background, then that would be what it is. But knowing that it's possible to take your time and feel like someone is understanding where you're coming from, that's possible, and you deserve that.
Yeah. Thank you.
But good question for the therapist. Has anyone experienced that? I know I have, in terms of Lisa's example of trying to navigate the wording. If someone feels very attached to their provider, you don't ever want to throw anyone under the bus. But at the same time, where does the education come in? Does anyone have like a clinical example of when that has shown up for you?
I can jump in there. I just had a client. I think they saw Mary Grace a couple days ago. They were seeing an outside provider because they set that up at the same time they set up the Light on Anxiety appointments. So they had no idea we even had that service. And then after a few appointments of working with this client, he was talking a lot about his like frustrations with his outside providers appointments. Like they were the very typical like 15-minute, check in. Is everything fine? What do you want? Okay, we'll renew the prescription. Goodbye. So I was like, oh, maybe he was like, oh, I wish I could find something a little more, somebody a little more that would listen to me. So yeah, we ended up setting him up with Mary Grace. I'll find out tomorrow when I see him how that all went. It looks okay in the note, but he'll tell me his own reaction. But yeah, really just. I also normalized it too of like, hey, I know for myself when I've seen medication providers, they're usually pretty quick, 15 minutes and leave. So it's just like trying to get him to also learn to advocate for himself too.
Yeah, that's what I like about Light on Anxiety, because they do offer the 30-minute appointments. So if there is a concern, like we can really hash it out. And like we have the time to be able to sit there and really listen to the concerns and what's going on with the client and answer questions that have come up with since starting the medication that a lot of providers, not by their own fault, just can't offer. They're being forced to schedule 15-minute appointments, or they have so many clients that that's all they can afford to give the clients. But I really appreciate here that we give the clients the full 30 minutes if they need it to talk and let their concerns be known and have their questions be answered.
jump in too. I just wanted to mention, kind of to Lisa's point, that it's often a thing I'm doing in intakes. As we're going through all of the bullet points of an intake, when we get to the medication part, like asking, like, I see this is a medication that you're already on. How's that going? Do you have who is the prescriber, so that we could do an ROI and connect if that's something that would be helpful. And if it's not helpful, if you're not liking that prescriber, that's boom. We have Mary Grace and Lauren here. They're super great. We have those extra 30 minutes compared to some other places. So that seems like just an easy, automatic way to do.
I'm still pretty new, but I've found like in a few instances in intakes, like same thing, you're kind of gathering that like medication information and checking in on that. And oftentimes somebody's getting prescribed from like a PCP. And then they're kind of like, yeah, and then that's kind of an in for like, oh, we have these services if you're open, if you want to even just like learn about other medications, like there's no pressure, and this resource is here if you need it. So I think again on that kind of empowerment route of here's the information, it's kind of a warm handoff and they feel like they have options.
Definitely. Especially with the PCPs, I've heard a lot. I mean, they're a generalist. So they know the Prozac, they know the Lexapro, they know the Zoloft, and they're not comfortable with anything kind of outside of that. Especially when we get into treating comorbidities, like we have anxiety and ADHD. So we have multiple medications that need to be kind of juggled. And they, again, don't have the time to really see the clients as often as might be needed for these types of medications. They'll give you the medication and say, see you in 6 months. If something really wrong happens, then let me know. And I'll see you every 6 months to re-up that medication. Whereas here we want to see you at least starting out every 2 weeks while we're adjusting the doses, and then every month. And then as we get more stable, we can push it out further as they become more stable and less in a crisis. But being able to have the flexibility of seeing these clients more often so that their medications, they're not struggling with these medications or just dropping them when they feel like they're not being listened to, is really important.
Just another shout out, I think, to our wonderful medication prescribers and patient-centric care and kind of right sizing it for the patient's needs. So a lot of places, no matter what, maybe it would be every 3 months or every 2 months to have an appointment to fill your prescription, versus if doing a lot more upfront when there is needs and exploration, but then once somebody's on a stable dose, getting that pace appropriate. Because another thing that can happen with patients is feeling like it's just this hoop to go through. It's not actually in and of itself helpful, but it's just this thing you have to do to get the medication. So I think really trying to target the patient's customized needs and come up with a plan based on that feels a little unique from what I see happening on the outside. And yes, this was so helpful, Lauren. Thank you so much.
Lauren, thank you so much. And just to speak to even working with Lauren and Mary Grace, they do the same onboarding. They have additional onboarding, but just being a part of the culture and loving what we all do. Lauren, thank you so much. This was really helpful.
Yeah, I appreciate you guys taking the time to listen. Thank you guys so much.
All right, have a